Good afternoon, everybody, and welcome to the CDC Public Health Grand Rounds. And I consider all of you extremely brave that you've managed to get through this awful weather in Atlanta. I don't know whether you had chains on your tires and boots and whatever, but thank you for coming. I would like to welcome not only you who are here, but a lot more people who are watching us live through major and several venues. And also would like to let you know how we're doing in terms of audience. Now, when one looks at the audience here, we might not quite see the numbers that you see on the screen, but we're actually getting enormous amount of people who are viewing us outside. And this is the graph that shows that on an average, we get between 10 and 11,000 people watching us live. This also shows that we are now on YouTube, and most of our events get about a couple of thousand viewers as well via that mechanism. Now, for those of us who are not into tweeting, Facebooking, my-facing, and similar thing, I actually had to be re-educated because CDC is on all of these, and as you see, we have advertised this event, and I do want to point that all the credit for these new technological advancements go to Shane Joyner, who is the one who reaches out to all these media venues and make these things possible. This is an event that is eligible for continuing education credit. And we get, on an average, 100 people getting the continuing education credit live, and then they can right now do that subsequently through our archived sessions. Thanks to Linda Valeroy and Debbie Burks for selecting the HIV topics for our weekly science clips. And I also wanted to make sure that there is a number of really exciting topics coming up in next year, and so please stay tuned. I do want to say that the Grand Rounds are not without challenges, and some of the challenges are shown here. This is just a subset of my own emails that I initiated yesterday afternoon worrying about bad weather. And I have stopped making fun of Atlantans for getting panicky with 2 raindrops, because this is what I caused. A number of people was emailing back and forth whether one of our speakers, Commissioner Farley, is going to be able to come from New York or not. And if you look at the folder under Tom, it says logistics, and I think I felt like I'm working for the UPS all day long on this project. Now, when you know who he is, and I Googled him yesterday, there's 2 million hits. I really didn't know that you're that popular. And I compared him to his movie twin, William Hurt, and you will see that he only got just half as many as William Hurt. So shame on William Hurt for not doing better. I would say that our guest is really doing fabulously well, and maybe here is a new career here. Now, one other thing that I do want to point out is that we have really an unbelievable set of speakers here. And we have been working on this presentation for a while and rehearsing, and I know that some of them feel like it's been really a long time since we started doing this, but also this is a group of people that is worked together so well for a long time that I'm pretty sure you will find their presentation to be one of the smoothest ever. And with that, I'm going to invite our director to say a few comments.
Just very briefly, HIV is a huge problem, both in this country and globally. Despite the fact that HIV is not nearly as transmissible as many of the infectious diseases that we work on, it is very difficult to prevent transmission. And yet, despite this, we have some hard-won progress in recent years. Treatment was the first, I think, big breakthrough in HIV, and we're now understanding increasingly probably in HIV prevention. I'm an infectious disease physician by training. I cared for hundreds and hundreds of men, mostly men, who died from HIV when there was no treatment available. And I recall in 1996, when I left the US to go to India and work on tuberculosis, having 2 close personal friends with AIDS and thinking that I would never see them again. That was just as highly active antiretroviral treatment became available. They're both working full-time now 15 years later. So treatment was the first substantial progress. PMTCT, prevention of maternal to child transmission, also critically important and very effective, and more recently, male medical circumcision. So we're gradually building our arsenal of things that can prevent HIV on a societal or mass basis, but still there are enormous challenges in HIV. It's my pleasure to welcome to CDC Tom Farley, who was advisor to me when I was health commissioner and a wonderful source of advice and insight, and I'm looking forward to his comments. It is an exciting time in HIV prevention and care because there are an increasing number of tools and an increasing awareness that by putting those tools together in different ways in different communities, we may be able to drive down incidents as well as deaths even more than we have so far. Thank you.
Oops. Oops. Sorry. I am. Oh, I may be at the bottom. Sorry. Yes, that's what I'm doing. Okay. Since we have lost 30 seconds here, I'm going to take it from Jono.
Thank you, Tanya. And she got my baby picture correct. I am the youngest on the panel. And I was a very fat 9-pound baby in the 50s, so thank you for getting the right picture. Good afternoon. I'm Debbie Burks from the Global AIDS Program, and today I will focus on the question of prevention, why now, and why again, and also serve as an introduction to the three following presentations. The number of new HIV infections has substantially declined. On the basis of the new UNAIDS report, in the past 8 years, the number of new infections has decreased 17% overall and 18% in sub-Saharan Africa. At the same time, HIV prevalence among young pregnant women, often due to ANC surveillance that CDC has supported, has significantly decreased in Botswana, Cote d'Ivoire, Kenya, Malawi, and Zimbabwe. Although we don't specifically know the interventions that have resulted in this dramatic improvement, the declines can certainly be attributed to the large-scale programs, both the Global Fund and the President's Emergency Plan for AIDS Relief, which brought scaled-up treatment services and care throughout the countries in sub-Saharan Africa through a strong partnership with host governments. This graph shows the tremendous impact of scaling up HIV services in resource-limited settings, bringing life-saving care to more than 10 million people over the life of PEPFAR to date, prevention of mother-to-child transmission to 8 million mothers, and treatment to 3.2 million individuals. Yet there remains a lot to do. The number of people living with HIV/AIDS is over 33 million, and we know that there are 2.6 million new infections per year. And where are these new infections occurring? They're still concentrated in sub-Saharan Africa, with over 1.8 million of these new infections. Why the current focus on HIV prevention? One, as Dr. Frieden has mentioned, we have new interventions that have been proven to be efficacious for preventing HIV infection. And two, CDC and PEPFAR, in partnership with host governments, have built major infrastructure within the health sector. Treatment scale-up has been a tremendous impact on the epidemic, but we know that treatment alone will not be sufficient to end the epidemic. But bringing together the same intensity of focus and commitment to comprehensive prevention interventions as we have done with care and treatment to date, we are ready now more than ever to bring these new life-saving preventive interventions into greater focus. We also have the prevention intervention platforms in which to build upon. We also need for more coverage of our currently shown efficacious intervention. As mentioned, male circumcision has been shown to be extraordinarily efficacious in 3 randomized controlled trials. Models suggest that 1 infection is averted for every 4 circumcisions in high HIV incidence and low circumcision countries. In addition, we have improvements in PMTCT interventions, as well as antiretroviral treatment as a component of prevention. Next, we have a series of promising interventions that are just on the horizon, including the new breakthroughs in HIV vaccines, vaginal microbicides, and pre-exposure prophylaxis. We'll be hearing more from pre-exposure prophylaxis from Dr. Merman. Ensuring the full utilization of our new proven intervention paves the roadmap for the immediate scale-up of these new interventions as they become available. It's very important that we look at what evidence we have for scaling up interventions and make sure that they have large public health impact, as shown in the far column, and across the top, strong quality of data to show their impact. We need to both impact and measure HIV incidence along the way to ensure the programs are efficacious. In analyzing both the potential public health impact of prevention interventions versus the quality of the data as shown, we know that we should focus our efforts in the circle where the most interventions have been shown to be both efficacious and have high public health impact. Effective programming will be guided by both the data and the targeting to specific populations at risk. And we need to evaluate and continue to evaluate the impact of all of our public health programming. As shown in this slide is one evidence of the evaluation and monitoring of our programs. This shows the scale-up of prevention of mother-to-child transmission, which has resulted by 2009, 3,400, nearly 3,400 infants saved from HIV/AIDS. Despite the fact that these new efficacious interventions are available, there is still a need for scale-up and coverage, and to ensure that we have a public health approach to universal access of these key interventions. We need to ensure the availability of counseling and testing as a portal, both to aggressive prevention interventions for the seronegatives, as well as a portal for service delivery to the HIV-positive patients. We still are less than 50% of where we need to be in these key interventions. So in conclusion, we have the public health sector platforms to provide integrated prevention. And what do I mean on this slide? It is critical to understand the overlay of both the proximate and structural determinants of sexual transmission of HIV. We know we must address the structural issues related to poverty and gender-based violence in resource-limited settings, as they have an impact on HIV. And Dr. Mercy today will address the role of gender-based violence and gender-based violence prevention as it relates to girls. This diagram shows the potential for leveraging our current platforms in the public health sector for integrated HIV prevention. We have the public health infrastructure at the health centers, at the laboratories, and at the hospital to expand services as well as provide these proven interventions. At HIV testing and counseling sites, we can both test individuals as well as provide safe medical procedures. The same with opportunities in care and treatment sites, antenatal clinics, and in male circumcision. Every one of these venues have the opportunity to integrate the current services with improved prevention messages and interventions. Dr. Merman will further discuss targeting Americans with HIV in healthcare settings, and Dr. Farley will further the discussion with presenting prevention interventions that are being utilized in New York City successfully. Thank you.
Good afternoon. If I knew we were going to be on YouTube, I would have set my talk to hip-hop and included dancing. In any case, so many of the issues that Dr. Birx highlighted in the global epidemic are also relevant to the U.S. domestic epidemic, though we have some different opportunities and some challenges. I'll present an overview of the HIV epidemic in the U.S., the new national HIV/AIDS strategy, and approaches to HIV prevention in healthcare settings, both for people living with HIV and people at high risk for HIV. There are 1.1 million people living with HIV in the United States, and about 56,000 new infections and 16,000 deaths annually, which means we have a net increase of about 40,000 people living with HIV each year. Because of advancements in testing and treatment, people with HIV are living longer, healthier lives, and people who start ART are expected to live at least an additional 35 years. The number of people living with HIV in the U.S., shown in red, has risen every year because survival has increased and the annual number of new infections in blue is greater than the number of deaths. This reflects the success of treatment and a partial success of prevention, as incidence has remained stable even as the number of people with the potential to transmit HIV has grown each year. This map shows the distribution of people with AIDS and its disproportionate geographic impact, especially in the South and Northeast. In fact, as you can see from this graph, half of all people living with AIDS in the US reside in 5 states, and 90% of all people living with AIDS reside in 23 states. HIV also highlights non-geographic health disparities. 95% of the people with AIDS are either MSM, African American, Latino, or injection drug users. 53% of all cases in the country are among MSM. African Americans are 8 times more likely and Latinos 3 times more likely to have HIV than white Americans. And MSM are more than 40 times more likely than other men to have HIV. Commissioner Farley will describe some creative programs that he's implemented in New York City among MSM. To better address these tremendous HIV-related disparities in a growing epidemic, the White House Office of National AIDS Policy developed the National HIV/AIDS Strategy. The strategy sets specific goals and targets for the next 5 years. The first goal is to reduce HIV incidence, to lower the annual number of new infections by 25%, and reduce the HIV transmission rate by 30%. The second is to increase access to and improve the quality of care for people with HIV, to increase to 85% newly diagnosed patients linked to care within 3 months of their diagnosis. And the third is to reduce HIV-related disparities, with the goal of increasing the proportion of people with an undetectable viral load by 20% among African Americans, Latinos, and MSM. Success in prevention will save lives and save money. The lines in this graph represent annual new HIV infections in different scenarios. The bottom line in yellow projects what would happen if we were able to optimistically reduce the HIV transmission rate by 50% within the 5 years of the national strategy. This could save between $44 and $104 billion. The response to HIV in the US has been championed by communities that have unique access to and trust in the communities most affected by HIV. In addition, leveraging the healthcare system could expand impact and support integration of prevention and care services. HIV prevention for people with HIV includes a wide array of services, and I'll discuss the first 4 in more detail: testing and linkage, ART, retention in care, and adherence and partner services. HIV testing is prevention. It is estimated that 21% of people with undiagnosed HIV infection in the country are associated with more than 50% of sexual transmission. And the 79% who are diagnosed are more likely to access prevention and treatment services and less likely to transmit HIV. Routine opt-out screening in clinical settings costs between $2,000 and $6,000 per person with HIV diagnosed. And testing matters not only for diagnosing infections, but identifying them early, when people have opportunity for early treatment and protecting partners. We've seen an increase in the number of people who have ever had an HIV test in the United States to 45% in 2009, and a concomitant reduction in the proportion of people diagnosed with HIV late in their infection. With diagnosis, people with HIV can access ART, which reduces mortality. The proportion of patients in an outpatient cohort taking ART in purple increased over several years, while the number of deaths decreased by 90%. In addition, ART is effective prevention and was associated with a 92% reduction in HIV transmission in a cohort of HIV discordant couples. And there's some evidence that there's a benefit not only to individuals, but to populations through reductions in community viral load. This study from British Columbia shows the association between increasing coverage of ART, the blue line, and the decreasing number of new HIV diagnoses per year, shown in red. It's also important that people with HIV on ART adhere to their medication for effectiveness of treatment and for prevention. The proportion of people with suppressed viral load increases with adherence, from 20% among people who report less than 70% adherence to 86% among people who report between 95 and 100% adherence. People can only take ART if they access care. Only 69% of people with HIV in the US attend a clinic within 12 months of their diagnosis. But there are services that improve linkage. For example, case management improves linkage by 32% at a cost of about $1,200 per person. And adherence interventions reduce viral load at approximately $35,000 per additional quality-adjusted life year. In addition, sexual behavior change interventions for people with HIV reduce unprotected sex by 43% and acquisition of STDs by 80%. However, effectiveness depends on the entire cascade from testing to care, and transmission reductions can vary from 15% to 44%, depending on drop-off along this continuum. An additional intervention is partner testing, which can reduce future transmission by identifying discordant couples and diagnosing infection. 20% of partners tested through provider notification had undiagnosed HIV at a median cost per new diagnosis of $7,800. There are also effective interventions in the healthcare setting for people at high risk for acquiring HIV, including behavioral risk reduction interventions, pre-exposure prophylaxis, which I'll talk about in more detail, and other. The goal of behavioral interventions is to reduce risk behaviors and increase condom use. Over 50 such interventions showed effect in controlled trials, and many have been implemented in clinical settings. For example, risk reduction interventions implemented in STD clinics reduce incident STDs by 17%. They are cost-effective. The median cost per HIV infection averted is $15,000. Due to time constraints, brief provider or computer-delivered interventions may be the most feasible to implement on a large scale. But some patients will need more intensive services and should be linked to allied health or community-based providers, especially those who address social, economic, mental health, and substance abuse issues, some of the same critical issues that Dr. Mercy will include in his talk. In addition to behavioral interventions, last month, results were announced from the first trial of pre-exposure prophylaxis. Taking daily a 2-drug combination ART pill was associated with a 44% reduction in acquisition of HIV among gay and bisexual men, raising important issues. Potential users are HIV uninfected persons at very high risk for HIV infection and unable to consistently use other prevention modalities. However, the ultimate cost effectiveness of PrEP will depend on incidence in target groups, the cost of medication and services. Currently, the drugs cost about $12,000 per year, and patients' ability to engage in risk reduction behavior and adherence to medication. Estimates of the cost per quality-adjusted life year range from $34,000 to over $300,000, depending on these factors. Policy change will be necessary if we're to fully integrate prevention into healthcare. Some useful CDC or HHS guidelines issued or in progress relate to testing, prevention with positives, ART, and male circumcision. Policies encouraging the use of quality measures and providing reimbursement guidance for services will be critical. 2 examples of focused program implementation include CDC's expanded testing initiative that targets 30 jurisdictions with more than 90% of the epidemic, and enhanced HIV prevention planning in 12 urban areas that have 44% of the epidemic that focuses on integrating prevention, care, and treatment services. So in conclusion, HIV is a major national burden. The success of the new strategy will depend on maximizing impact and a collective commitment to the vision that the United States will become a place where new HIV infections are rare, and when they do occur, every person, regardless of age, gender, race, ethnicity, sexual orientation, gender identity, or socioeconomic circumstance, will have unfettered access to high-quality, life-extending care free from stigma and discrimination. Thank you. Now, Dr. Mercy.
Good afternoon. I'm Jim Mercy, and I'm from the Division of Violence Prevention. Childhood sexual violence is a serious human rights and public health problem. Exposure to childhood sexual violence has important implications for HIV infection, especially in countries with high HIV prevalence. I will discuss the association between childhood sexual violence and HIV and the need for a strong foundation of surveillance data on this issue. To illustrate the value of such data, I will use the results of a survey of sexual violence against girls in Swaziland and link those results to promising prevention strategies relevant to both childhood sexual violence and HIV. Girls are disproportionately impacted by sexual violence. WHO estimated that 150 million girls and 73 million boys had experienced sexual violence in 2002. If these 150 million girls constituted a country, they would represent the 8th most populous country in the world. Consequently, this presentation is focused on girls. Adolescents make up the fastest growing group of HIV-infected persons worldwide, with half of all incident cases found among youth aged 15 to 24. This trend is especially pronounced in sub-Saharan Africa. Sexual violence increases the risk of HIV infection and a broad range of other mental and physical health problems. Childhood sexual violence has the potential for contributing to HIV via 3 routes. First, forced intercourse with an infected partner can lead to direct transmission of HIV. Girls are biologically more vulnerable to contracting HIV than adult females, and perpetrators of sexual violence are more likely to be HIV positive than non-perpetrators. Second, since sexual violence against girls is often associated with physical violence and perpetrators that are more powerful than their victims, there is very limited potential for negotiation of safe sex practices such as condom use. Third, exposure to childhood sexual violence leads to HIV risk behaviors such as not using condoms, transactional sex, multiple partners, and substance abuse. Swaziland was the first location for a series of national surveys on sexual violence against children that are ongoing in sub-Saharan Africa. Since the early 1990s, it has experienced a prolonged economic depression coinciding with an overwhelming HIV/AIDS epidemic. In 2006, CDC, UNICEF, and the Swaziland government formed a partnership to conduct a national survey. The survey was motivated by the lack of objective information on the magnitude of childhood sexual violence, as well as its relation to a range of health and social problems, especially HIV. The purpose of the Swaziland study was to describe the magnitude of the problem and assess health consequences, to identify potential risk and protective factors, and to assess utilization of services, and ultimately, of course, to use the data to help guide programs and policies to prevent violence against children. The study was a 3-stage cluster design household survey in which 13 to 24-year-old girls were interviewed. Our results indicated that 1 out of every 3 females 13 to 24 years old report experiencing some form of sexual violence before their 18th birthday. The most common forms of sexual violence included attempted unwanted intercourse and unwanted touching. Furthermore, almost half of those who experienced sexual violence as a child experienced it more than once. Exposure to childhood sexual violence was significantly associated with an elevated risk for a range of health conditions. The strongest of these associations was for sexually transmitted disease, including HIV. Victims of childhood sexual violence were at almost 4 times greater risk of having an STD during their lifetime than non-victims. The most common perpetrators of sexual violence against girls were all persons known to the victim: men and boys from the neighborhood, boyfriends, and male relatives. Perpetrators tended to be substantially older than their victims. These data point to a need to address norms that underlie cross-generational relationships. Asymmetries between girls and older male sexual partners in power make these relationships inherently risky for both violence and unsafe sex. The Fataki campaign uses radio and billboard messages to create a social taboo against cross-generational relationships by portraying the fictional Fataki as being thwarted in his attempts to seduce girls by family, friends, and neighbors. Initial tests in Morogoro, Tanzania, found this program to increase the percentage of community members who say that they could do something about these relationships from 64% at baseline to 88% at post-test. In general, we found that victims rarely receive and may not even be aware of health or counseling services that have the potential to mitigate health consequences and even save lives. Only 14% of victims of childhood sexual violence received any services after their exposure. This included any kind of health, social, or criminal justice service. Only 16% were aware of the availability of post-exposure prophylaxis services. Post-exposure prophylaxis, or PEP, is a 28-day course of antiretroviral treatment that, if administered within 72 hours, can reduce the likelihood of seroconversion among rape victims. It has been demonstrated to be about 80% effective in reducing seroconversion after occupational exposure to HIV in the U.S. PEP can be provided in an affordable and cost-saving manner in high HIV prevalence countries. In South Africa, the net cost of PEP per life year gain was estimated to be about $2,000. Another key area explored in this survey is the role of parents in protecting and providing information to children. Having a close relationship with one's mother cut the risk of childhood sexual violence by over 50% relative to girls who had no relationship with their mother. We also found that parents are not a primary source of health information. Only 16% learned of HIV/AIDS and 34% about safe sex from their partners, from their parents. The SWASI data point to the quality and reliability of a girl's relationship with her parents as being critical for protection and information. Families Matter, developed by CDC, is a U.S.-based, evidence-based intervention designed to improve parent-child communication about sexual risk reduction, now being applied in sub-Saharan Africa. Initial results from rural Western Kenya indicate that Families Matter enhances parenting skills and communication around sexual topics. For example, at post-intervention, 50% of parents report that their child asked them about a sexual topic versus 14% at baseline. Fully addressing the intersection between childhood sexual violence and HIV will require public health to engage in new partnerships. Together with Girls is a partnership that brings together the private sector, UN agencies, and the U.S. government, as listed here, to end sexual violence against girls. This partnership was established in 2009 and is organized around 3 pillars: generating data to guide action, supporting governments in evidence-based prevention and response, including support of legal and policy frameworks, and mobilizing action through communication strategies. Ending sexual violence will allow girls worldwide to live safer and healthier lives. Public health has a critical role to play in this effort. And now let me turn the podium over to Tom Farley.
Well, good afternoon. It's a pleasure to be here in Atlanta. I see so many colleagues, past and present, in public health. I want to talk about a brief review of the epidemiology of HIV in New York City, with a particular focus on resurgence of transmission among young men with sex with men. And then I want to talk about a few selected prevention initiatives that either we're doing in New York City or that I think deserve more emphasis. First, a very quick overview of the epidemiology of HIV. Since the beginning of the epidemic in New York City, as in other areas, we had a rise and fall in AIDS cases. We had a rise and even steeper fall in AIDS-related deaths. And as a result of the success of HIV treatment, we now have a very rising HIV prevalence. In New York City, we now have 107,000 people who are known to be infected with HIV. That number is rising by about 2,000 to 3,000 per year. So my first point here is that the success of treatment should not make us not focus on prevention. If anything, it should make us focus even more on prevention of this problem in the first place. This is where we are now as far as new HIV cases reported to the City Health Department. It's about 4,000 per year, and it seems to be going in the right direction, a general decline. That decline, though, is masking changes that are fairly rapid in the different risk groups within the overall epidemic. We're seeing sharp falls in the number of new cases of HIV infection in injecting drug users and in heterosexuals, but a stabilization, a plateauing of the number of new HIV infections in men who have sex with men. That, in turn, is also masking very sharp differences by age group among men who have sex with men. We are seeing high rates, but falling rates of new HIV cases reported in men of sex with men over the age of 30, but rising rates, and actually fairly rapidly rising rates, of new HIV infection among men under the age of 30. Now remember that HIV infection reported to us often is going to represent infection that has occurred some years in the past. So if we really want to understand where the leading edges of the epidemic, this isn't going to be the best data source for that. We have a surveillance system in New York City where we are gathering information on acute HIV infections. These would be people who have either had a seroconversion that was documented, or have a positive antigen test or a negative antibody test, or have had an acute HIV illness syndrome. There are some biases to this surveillance system. Nonetheless, I think it gives us the best picture on where is the leading edge of the epidemic in New York City right now. And as you can see, for the 2-year period, 08 to 09, of the 193 cases that were reported to us, 74% were men with sex with men that were known to have that risk factor. If you limit this just to those for whom we have a known risk factor, it's 86% with men with sex with men, or 90% if you include those who are also injecting drug users, suggesting that the vast majority of this epidemic right now is in men with sex with men. So what do we know about the risk behavior of men with sex with men in New York City today? This is just a data from National HIV Behavior Survey of men with sex with men. And these men are recruited from MSM venues, and so there's some bias to this. It suggests, though, that the majority of men with sex with men have relatively low numbers of sex partners. This is the number of partners in the previous year. However, we do have 15% who are reporting 10 or more partners per year. So there's still a substantial subpopulation that has very large numbers of partners. We're also finding that condom use among men with sex with men is occurring commonly but inconsistently. Among overall men with sex with men, 35% are reporting not having used condoms at the last anal sex. Among those who had anal sex with an HIV positive partner or partner of unknown status, it's 15% that did not use a condom. Among those who were HIV infected at their last anal sex, 35% did not use a condom. Likewise, disclosure of their HIV status is inconsistent. Only 62% of men said that they knew the HIV status of their last partner, and 41% said that they discussed HIV before sex with all of their past year partners. We have, there's some data we can pull on where we can reach men with sex with men from our partner notification data. We interview people who are newly diagnosed with HIV to identify their partners. And this is not collected in a systematic way, but by going through these interviews, we're able to pull information on where they met their last partner. So this is among newly diagnosed with HIV men with sex with men. And as you can see, the two main sites here are bars and clubs and the internet. And so those provide, to me, the greatest opportunity for us to reach men who have sex with men who are at the highest risk. So now let me talk about some prevention initiatives that we are, again, either involved in or that I think deserve more emphasis. I'm going to talk about expanding HIV testing and linkage to care, prevention with positives, condom distribution, use of mass media for risk reduction messages, and reducing alcohol use. First, expanding HIV testing to care. We have an initiative in the Bronx, which is one of the 5 boroughs in New York City, where our stated goal is to try to test every adult with HIV. This is a borough that has 930,000 adults. And over a 2-year period, we've tested nearly 400,000 adults. These are the sites in which they've been tested: hospitals, community health centers, and community-based organizations. We have 3,200 confirmed positives, and of those, about 1,200 were newly diagnosed. Overall, within the Bronx now, 45% of people report that they've been tested in the previous year. This is on telephone surveys. This is information on the issue of prevention with positives, and it comes from this is from a mathematical model. It's addressing the question of whether we achieve more prevention of HIV infection by counseling people who are HIV positive versus those who are HIV negative. This is a simple Bernoulli model where it assumes that at baseline 60% of people are using condoms, and it asks the question, how many HIV infections can we prevent by increasing condom use among either the positives or the negatives? And as you can see, we can prevent, by increasing condom use to 62% from the HIV positives, we can prevent more infections than if we increase condom use among the HIV negatives to 75%. As far as prevention with positives goes, we know that positive men are frequently having risky sexual behavior. From surveys we have approximately 3/4 of HIV-positive men and 57% of HIV-positive women remain sexually active. About half of those engage in unprotected anal sex. A national survey showed that 14% of physicians say that only 14% of physicians say that they provide HIV risk reduction counseling to established HIV-positive patients. And in data from New York City, we know that 39% of sexually active HIV-positive men in care received one-on-one risk reduction counseling. So it emphasizes the importance of risk reduction counseling regularly by providers. Now I want to talk a little bit about mass condom distribution. This is data that we generated from Louisiana when I worked there in the 1990s. At that time, we started out distributing relatively small numbers of condoms, but then in 1994, we started a mass condom distribution program where we were distributing between 1994 and increasing to 1996 close to 14 million condoms, or that's 3.3 million condoms 3.3 condoms per capita. That's shown in the bars there. What's shown in the line here is the condom use at last sex on sexual risk behavior surveys done in sites other than where we were distributing the condoms. As you can see, as the number of condoms distributed increased, we had an increase in self-reported condom use. We then had a budget cut in 1997, and so we reduced the number of condoms distributed, and we had a reduction there in self-reported condom use that was in parallel with the number of condoms distributed. And if you follow that graph on out, it seems in general there was a parallel between the number of condoms distributed and self-reported condom use. This is just an ecologic association, but there have been other studies, and in fact a meta-analysis which shows that the more condoms you have distributed, the more people are likely to use them. I say this because although health departments around the country distribute condoms, very few of them distribute them to the extent in which I think that they can be effective. Again, this is a large number of condoms, and we put them in places in New York City where people are most likely to want to come in contact with them. So in New York City, we now distribute over 40 million condoms per year. That's 5 per capita. They're being distributed in bars and clubs, over 3,000 venues in total. We have specifically tried to identify every site in which men who have sex with men come in contact with each other. There are several hundred of those sites which we have identified, and we do regular spot checks to make sure that the condoms are available in those sites. Of those, we have 93% say that 93% are available when we've done those observations. So these are a couple of examples here. This is a bar with a condom in the fishbowl on the counter. And on the right there, there's an actual condom dispenser that we developed, which looks conveniently like a condom, that has condoms that come out of the bottom. Now, risk reduction messages. We have to reach a large number of men who have sex with men with prevention messages. In New York City, we know we have more than 100,000 men who have sex with men. We're not going to reach all of them through one-on-one, face-to-face interactions. And so we feel we need to use mass media. We've done focus groups on young minority men who have sex with men and learned from those focus groups that they're surprisingly and worryingly unconcerned about HIV and that they had not seen prevention messages. So we've developed media messages directed specifically at young men who have sex with men, particularly those who are minority, to emphasize the continued risk of HIV even in the era of HIV treatment. And I want to show you this example, which just came out in the last few days. This comes up.
When you get HIV, it's never just HIV. You're at a higher risk to get dozens of diseases even if you take medications, like osteoporosis, a disease that dissolves your bones, and dementia, a condition that causes permanent memory loss. And you're over 28 times more likely to get anal cancer. It's never just HIV. Stay HIV free. Always use a condom.
All right. Finally, I want to talk about the relationship between alcohol use and HIV risk, and to emphasize the point that this is something we need to be doing more on. In surveys we've done in New York City, we know that those people who are binge drinkers are far more likely than alcohol drinkers who don't binge drink to have large numbers of sex partners. In this case, shown on this graph, 5 or more partners over the previous year. Likewise, far more likely to have large numbers of partners than those who are non-drinkers. And if you look at the frequency of using alcohol before sex or being under the influence of alcohol or drugs before sex, men who have sex with men are far more likely to be under the influence of alcohol than they are of illicit drugs. So we have close to 40% are under the influence of alcohol at the last sex versus close to 19% who are under the influence of drugs, and there's an overlap between those. So for all of the emphasis we have had over the years on things like crystal meth, alcohol is probably more important as far as at least people being under the influence of that during sex, and as far as HIV transmission, than those illicit drugs. Similarly, the use of alcohol, or the connection between alcohol and risky sex, increases with the people who have large numbers of partners. So according to this behavioral survey we've done in New York City, among men who have sex with men who report 20 or more partners in the last year, close to 50% were under the influence of alcohol at the last sex. All of that so far was just ecologic data showing an association, and people may argue that it's not necessarily causal. So the question is whether, to determine if it's causal, whether changes in alcohol availability would be reflected in changes in sexual risk behavior and outcomes. Indeed, that's the case. This is a study that was done by CDC some years in the past. It demonstrated that when states increase alcohol taxes, they were followed by reductions in alcohol consumption and reductions in sexually transmitted diseases. And they even put an elasticity to it, that a 20% per pack increase in the beer tax is associated with a 9% reduction in gonorrhea among teens and among young adults. Again, not perfect randomized controlled trial data, but arguing that alcohol itself may be a causal factor for STD and HIV transmission. So let me then just finish with where I began, that this is the quote from Bill Gates, that the harsh mathematics of the epidemic prove that prevention is essential to expanding treatment, that stressing treatment without paying adequate attention to prevention is simply unsustainable. Thank you.
Thank you, everyone, for outstanding presentations. And I think we're now open to questions from.
Okay.
Please.
Bob Brewer, excellent presentations. I'll get the ball rolling and pick up on Tom's last point about the connection between alcohol and risky sexual behavior. But actually, not to ask about sexual behavior, I wanted to ask about violent behavior. We know that excessive drinking plays a large role in homicide and other violent crime. We know less about the relationship, at least based on my knowledge, of the role of alcohol as a risk factor for perpetrating intimate partner violence. And here I'm particularly interested in sexual violence. And I'm curious, Jim, in the study that you were involved in, did you have an opportunity to assess specifically the role of drinking to excess, binge drinking, as Tom pointed out, as a risk factor for perpetrating sexual violence?
No, in this study, we couldn't look at risk factors for perpetration. We were able to look at risk factors, the consequences of victimization for things like alcohol use and substance use. But I think there's two things that are important. One, I think other research supports the finding that substance abuse and alcohol use increases risk of things like child maltreatment and sexual abuse. But it's also a consequences of sexual abuse. And as Dr. Farley said, this sort of substance abuse can lead to high-risk behaviors for HIV. So there's an indirect relation between exposure to violence, substance abuse, and risk for HIV that I think is important to recognize.
Good. Thanks.
Yeah, Debbie Birx quoted the UNAIDS report saying that HIV incidence had been reduced by 18%. And John, you told us that it hasn't been reduced at all in the United States. So what are they doing right, or what are we doing wrong?
It's a complex question and answer, Harold. I think one issue is that we have pretty good measurements of incidence in the United States, and our epidemic is older than many other countries. So most epidemics have trends that change over time, and a fair proportion of the reductions that have occurred internationally have occurred in South Africa, which had an epidemic that started later than many other countries, reached a peak where it was involved with over 20% of all the new infections in the world, and then is now slowing down. And it may be that some of this is a tendency that's happening in epidemics as they mature. The second part is that many countries, especially in sub-Saharan Africa, the leading cause of death is HIV. And in some, over 50% of all people who die of HIV infection. And so the social context for understanding HIV is tremendous. People have their parents die of HIV, their friends, their relatives, their brothers and sisters. It's integrated into their existence. Whereas in the United States, we had that, especially in subpopulations like gay and bisexual men, early on in the epidemic, and people changed their behavior. And we saw the incidence of HIV change from 130,000 estimated infections per year in the 1980s to about a little over 50,000 now. So we've seen some change in the U.S., I think because people reacted to the epidemic. But recent data indicate that Americans don't prioritize HIV as a major public health issue now the same way they did a decade ago. So all of those factors and others may have played into the fact that we're seeing reductions internationally, and at this current time we don't see the reductions that we'd like to see in the U.S. Tom.
Maybe for Tom or Jono or Debbie, can you talk some about what you see as the role of condoms? There's been a lot of effort to ensure that they're widely available. The impact on behavior and safety is less clear, but they're so inexpensive that it makes sense to try to make sure they get everywhere. But what do we think? Is this going to be a tool that is of decreasing effectiveness, or something that we are emphasizing inadequately?
My feeling is it's a tool that we're emphasizing inadequately, that all health departments distribute condoms, but they may distribute 100,000 condoms and think that they've done a lot. But condoms are not available in the environment in most places in the United States, I don't believe. We're not going to get condom use to 100% by making condoms available, but if you can boost it even by 5%, that's certainly going to be cost effective because condoms are so cheap. So to me, it's a basic thing we ought to do first as a very inexpensive intervention to set the stage for reducing risky behavior.
I agree. In some ways, condoms are the mainstay of HIV prevention, and we really haven't maximized their availability or access, especially to those people at highest risk. We also have to have the norm be, as the video that Dr. Farley showed, be that everyone is using condoms. If the assumption is that I should be using a condom, then people will start using them more. And so that is an area that our division is working to expand both access and use of condoms. Policies related to condom distribution and availability, and then also to understand how condoms can be used more in the context of knowing one's testing status. So in people who are in a long-term couple where one person has HIV and the other doesn't, condom use and availability is both critical from a public health standpoint as well as an individual protection point, and they'll be necessary for the length of that relationship.
Just a quick comment, just to bring your question, Harold's question back together. I think part of the difference obviously is the generalized epidemic and being able to address young women and young male behavior. And a lot of the drops in incidence in Africa is with young women, to decreasing incidence among young women. And that's pretty clear that prevalence decrease has to reflect an incident decrease. I think the condom use in Africa, as the teams have probed and really gotten good questionnaires out there, it's primarily not the availability, but it's the individual's determination of whether they need a condom, and a lot of determination that in stable relationships they choose not to use for cultural reasons. And I think both the Together for Girls and other structural groups are really looking at how to change that relationship and how to get people their default to be condom use, because it's very much a symptom of unfaithfulness if you choose to use a condom. And it has really nothing to do with a dialogue, but assumptions that are made.
Thank you, please.
I'm Diane Bennett from the Global HIV/AIDS Division, and I wanted to ask about PrEP, specifically what groups, if it's proven to be effective, well, it has been now, should it be targeted to, and specifically in serodiscordant couples, would people recommend that you treat the positive partner or that you provide PrEP to the negative partner?
Well, the first is CDC will be leading the development of formal public health service guidelines regarding the appropriate use of pre-exposure prophylaxis. Because the two-drug regimen that has been evaluated in the recent study is available for treatment, clinicians can prescribe it at the current time off-label. And so we are trying to work out some interim guidance that will help both potential users and their clinicians to think through some of the issues that will come up. It's clear that PrEP is most useful for people at very high risk of HIV infection who are unable to continue using other potential interventions. It's not going to be a first-line intervention. It's for people who are still have sexually transmitted diseases or multiple partners and unprotected intercourse and are at what we would help them realize is continue to be at very high risk of HIV acquisition. It's also a very expensive intervention, and so we would have to, some people it will be unavailable, and we don't want to have a situation where pre-exposure prophylaxis exacerbates some of the disparities that already exist in society. So all of those issues will have to be dealt with. In terms of the populations who would potentially benefit, this study that showed efficacy results was only among gay and bisexual men and a very few number of transgender women. There are other studies, including one that CDC is involved with in Thailand, that looks at the potential efficacy of pre-exposure prophylaxis among injection drug users, and other studies looking at heterosexual men and women. When the accumulation of evidence comes, hopefully it will be in the same direction. That will enable us to make more assessment of the potential use of pre-exposure prophylaxis even more widely. But right now, the guidance that people are developing is related to gay and bisexual men.
And the serodiscordant couples question?
Oh, I'm sorry. And serodiscordant. Well, at the current time, it would be gay and bisexual serodiscordant couples. But I think in the future, if the studies show efficacy, one of the potentially useful situations would be in HIV discordant couples, because the incidence without knowledge of status is as high as 10%. And so even with knowledge of HIV status and access to condoms, many discordant couples studies have shown incidence of up to 4 or 5%. So they would be an appropriate place to consider the potential use of PrEP.
But both you and Dr. Birx quoted the studies showing efficacy of treatment in the positive partner to prevent transmission. So wouldn't you go that way instead?
I think we'd have to consider all the different interventions. So for discordant couples, there is a question about certainly whether the increased use of antiretroviral therapy, especially for people with high CD4 counts, would benefit both their care and transmission, and then pre-exposure prophylaxis in the discordant partner. And people are looking into that both from a modeling standpoint and potentially from an individual benefit perspective. Obviously, condoms would also be encouraged in that situation.
Thanks.
Tom Sinks. Obviously prevention is extremely important. Behavioral modification is very challenging. The HIV epidemic is a classic example of that. Can any of you tell us where we are in terms of the future for an effective vaccine?
That was my previous life before coming to CDC 5 years ago. And I think until we had the Thai trial, there was a lot of discouraging, and I think there's a whole series of trials built around trying to reproduce the Thai trials in different populations, as well as utilizing new immunogens. And I think it's really reinvigorated the entire HIV vaccine field to both look at it from actually prevention of acquisition. That was a huge breakthrough, but before that, they were very much focused on preventing disease and affecting viral loads. So I think both the antibody groups that are working on improving antibody responses, as well as the T-cell groups improving T-cell responses within vaccines, are bringing those two groups together. And everybody is very encouraged that we will have 2 or 3 major trials launched within the next couple of years to really validate the impact of the Thai trial. So if you had asked me 3 years ago, we would all been quite discouraged, but I think the field is quite invigorated by both that finding in Thailand and the Caprisa trial in South Africa.
Thanks for all of your talks. For those working domestically, what do you see the role of opt-out testing, opt-out testing policies in terms of increasing the number of unknown positives in the United States?
The New York State Legislature passed a law that makes mandates that physicians offer HIV testing to everyone between the ages of 13 and 64 with an opt-out. And I think that our goal is to make HIV testing routine in medical care. Obviously, people have the choice to opt out. And I think that's the only way we're going to get to identifying all or even a high percentage of the positives.
I'd just add that right now about 45 states have policies that support opt-out HIV testing that are in line with our 2006 CDC recommendations. In addition, in at least one study of high-risk MSM in 21 cities in the U.S., 75% of the men who had undiagnosed HIV infection had visited a healthcare setting in the prior year. So the offering of HIV testing to people who come to the healthcare setting has high acceptance rates, and it could potentially also dramatically increase the proportion of people with HIV who know that they have HIV. One of the challenges we have is actually operationalizing that. So now that the policies are in place, that it needs to actually be implemented. And although we've seen increases in the proportion of all Americans who have had an HIV test and in those at high risk who have had a test in the past year, it's not to the level that we need to truly maximize effect on the epidemic. And then the second area is really linkage to care and retention in care. We are increasingly interested in making sure that the people who have been diagnosed overcome the obstacles that often prevent them from accessing care and prevention services. Just by being cared for in that setting, people reduce their risk behavior, they're able to access antiretroviral therapy and other social services, and it's of a public health and personal benefit.
Just a quick 10-second note on resource-limited settings. Until the policy change of opt-out in PMT-CT, even in high-coverage countries, the rate of infections remained at 10 to 12%. And with the policy change of opt-out, Botswana and other countries have decreased transmission into the 2 to 3%. So it's also critical in resource-limited settings.
There are actually two, Tanya. Could we have two questions? Okay. Okay, please go ahead.
Hello there. Good afternoon. Thank you for your presentations. My name is Joanna Hillman, and I'm an informatics fellow in the Global AIDS program. I was hoping that one of you might be able to elaborate a little bit on the computer interventions for behavior change that were mentioned. If someone could comment on that, I'd appreciate it.
In the brief time, I'll just say that the people have been exploring kind of computer interactions, both to collect information for people at continued or potentially continued risk of HIV infection, and also providing information. So if people are in a clinic setting, to be able to sit down and they can essentially, in a comfortable environment, report risk behavior or not, and then also get guidance from that program about what they might need to do to decrease risk. And that's been shown to be successful in some studies, both in the United States and internationally. And I can put you in touch with some of the people who are involved in that groundbreaking work.
Thank you all very much for being a wonderful audience, for your great questions, and for being here. We will see you next month, same time, same place. And please, let's give one more round of applause for our speakers.